Thanks very much for the opportunity to speak on elective blood management. Are drains still needed in the era of tranexamic acid? If you want this presentation copied, I'll just send it to you at my email address, which I've put up there before. So a declaration of interest really doesn't have anything to do with what I'm going to speak about. So I think a better alternative title for this would be How to Avoid Blood Transfusions. There's increasing evidence of adverse effects of transfusion with immunomodulation leading to infection. There's two papers just this year alone looking at allergenic blood transfusions and post-op infection. This one from a large DVT PE cohort. And similarly, it's another paper from Duke University, and both had increased rates of infection after allergenic blood transfusion. So clearly, not only have to consider the infection risk, we have to consider the monetary costs. That's the cost of giving the blood. Someone has to give it, drive to the red blood clots, donate their time, give the blood, then someone has to store it, transport it, take it to the hospital, someone has to put it up, running through a drip, etc., monitor the patient. So it's a huge amount of cost there in monetary costs. The other is opportunity cost. If there's two forms of opportunity cost here, or really three. The first is the person giving the blood, wasting time. They could be out working. Or the person receiving it is receiving blood when they could be up around rehabilitating. And finally, there's opportunity cost in terms of someone who actually also needs the blood may not be able to get it. The issues of predicted demographics as well, because clearly we've got an aging population, there's more need of blood transfusions, and a smaller proportion of people are able to give blood just through age. Blood also has, or stored blood, has decreased efficacy when compared to patient's own blood. And there is a significant rate of adverse transfusion reactions as well. Interestingly, it's difficult to show that post-op anemia is related to quality of life. So this paper here, they struggled, or they didn't show any measurable quality of life issues. But the problem with anemia is it's often anemia is just measured as two standard deviations below the mean, or in fact someone could be quite symptomatic of anemia and not even be two standard deviations below the mean. In my own patients, this is just the knee replacements since November and January of 2012, and over essentially the last 2 years since the introduction of measures to avoid transfusion and blood loss. There's been a slow and steady decline in my average inpatient stay length down to an average of 3.7 days. And that's all comers. That's not people who are excluded only going to rehab. That's just the raw data. Average length of stay, 3.7 days. So it's been a significantly decrease or a change over time. I think we should all think of the term of haemovigilance, and that is the actual preservation of patients' blood. It's not my term, but it's a term from the BEST group, the Australian Better Safer Transfusion Group. 32% mean perioperative transfusion rate of 100 to 15%, with total hips having the highest and total knees having the lowest. They also reported 12% of patients are actually over-transfused. Now, I'd like to put to you that these two articles you should really read. The first is by Warwick Bruce on practical recommendations of patient management of blood. This was in the Australian New Zealand Journal of Surgery about 2 years ago. It's an excellent article. It talks about all the available evidence for different practices. I'd highly recommend you read it. I did at the time. I thought it was excellent. I put it away for further reference, and I still actually refer to it. It's getting a little bit dated now. There's some changes in or increased data over the last 2 years, which I'll add into this talk as well. The other is the National Blood Authority's blood management guidelines. It is excellent. And there's a number of really helpful diagrams which I'll give to my nurse, but particularly if patients come along they're anemic, then they should be preoperatively screened, specifically looking at their iron stores. So haemovigilance can be divided into what you should definitely do, what you may consider doing, and then what you should avoid doing. So what should you definitely do? I think there's 8 things that I think we all should consider doing or do. They are screened early for anemia and stratified by bleeding risk. So somebody who's a 60-year-old male undergoing a knee replacement with normal iron stores is not going to be at risk of a 85-year-old with a known history of anemia or a bleeding disorder undergoing a revision total hip. So you have to screen early and stratify by bleeding risks. If you need to stop everything you can, including all the antiplatelets, anticoagulations, and complementary therapies if possible, that should be stopped. Patients who are on krill oil and other complementary medicines, devil's claw, etc., they actually have anticoagulative problems. The patient should arrive in the theatre warm, not anemic, and with adequate iron stores. And that's, I think, a given. If people turn up, they're cold, they're already in preoperative, and they arrive in theatre, they're going to drop their core temperature by 1.5 to 2 degrees as soon as you put them to sleep. You should use hypotensive or normotensive anaesthesia, be it a spinal or a general anaesthetic, using practical techniques to drop the blood pressure or keep the blood pressure normal. A meticulous hemostatic technique is important, particularly plugging the femoral canal. You should actively warm your patient during the surgery. There's evidence that aggressive warming does decrease blood loss. And you should look at flexing the total knee replacement post-operatively for 6 hours using compressive dressings. There's 2 recent studies supporting the use of doing that. Probably not more than 6 hours, a increased rate of altered sensation post-surgery. I think if you're not using tranexamic acid and you're doing arthroplasty surgery, you really are missing the boat. I think one thing you're going to learn from this presentation is you really got to use tranexamic acid. It's vital and important to use. This is a meta-analysis from just about 2 months ago. They looked at 46 randomized control trials, almost 3,000 patients. The decreased total blood loss average was 408 mil. That's almost a unit of blood. And they showed that mean average loss or reduction of mean average loss was almost over 400 mils. About 125 mils of intraoperative blood loss, 214 post-op, and they reduced the number of blood transfusions by 0.78 units, with no increased risk of DVT. So I think if you're not doing all those things, you should be. Now, what you may consider doing. So I think you really care about losing blood or maintaining hemoglobin. You probably want to use a tourniquet in total knee replacement, as it's probably its benefits are greater than its disadvantages. I've gone from not using a tourniquet to the last couple of years swapping back to using it, as I've decided to try and not give patients transfusions. Look back at that group, I've only actually given one person a transfusion in 2 years from all the total knees I've done. If you're going to have more bleeding than usual, cell save or at least pre-autologous blood donation is important. I wouldn't standardly do it, but if you're going to have more bleeding, then you probably need to consider that cell saving. I tend to find the cell saving better, but we have that set up in the hospital, so it's good to keep using it because it keeps up the technologist's skills, and when you really need it, it's not such a drama. You can't just put drains in and let them drain without at least clamping them, or if you're going to do total hips, consider retransfusing drains. There's evidence to support that over just continuous suction. And you don't want to bridge your AF patients, so atrial fibrillation patients prior to surgery. There's increasing evidence that is not necessary. Now, if you're going to use patients with tranexamic acid, you may wish to consider not using drains at all. There's lots of studies looking at temporary clamping and tranexamic acid in combination, but there's no study yet that compares no drain of tranexamic acid with temporary clamping and tranexamic acid. So look at this study. They had Group A, Group B, Group C, Group D, all different variations of control or clamping or tranexamic acid, but it missed out on one vital group, and that was no Group E, no drain and tranexamic acid, which was a bit unfortunate. Now, the other option, if you don't like giving patients IV, or everyone puts their hands up in horror and say you can't be giving that, everyone's going to have blood clots or heart attacks, then you can just use local and you can just pour it in the wound. So there's been 2 randomized control trials in the Journal of Arthroplasty just this month. They haven't actually been published. They're in press as I was researching this. No difference for both total hips and total knees with topical versus IV tranexamic acid. So if you don't want to give it IV, which I actually don't do, I just give it topically, you can happily do that. You want to consider starting at patients on aspirin on discharge rather than immediately post-op. So if you're not going to use aspirin as a prophylactic for thromboembolic events, but just because the patient's on it, because they've got a risk of myocardial infarction. This study, which was just in March of this year in New England Journal of Medicine, over 10,000 patients, aspirin versus placebo. 65% had prophylactic anticoagulation. So it stayed in there. You can't use this study as to looking at aspirin's effectiveness in preventing PE-DVT. So if you're using aspirin for PE-DVT prophylaxis, you don't reference this article at all. But interestingly, aspirin in the perioperative phase did not prevent death or non-fatal myocardial infarction. It was the same. So in the perioperative period, there's no reason to be on aspirin, and you might as well stop taking it pre-surgery and then only really start it again post-surgery. So the increased risk of major bleeding was significantly increased with aspirin use, and it was only until about day 8 or 9 that the risk actually reverted to being non-significant. So suggest avoid aspirin pre-surgery and post-surgery if using another chemical prophylaxis. Okay, what should you avoid doing? These are things that you shouldn't do. So avoid continuous drug suction drains. I've touched on that. Don't catch up with post-operative oral iron. You're sort of chasing your tail and it's not all well absorbed. So you just can't give people some oral iron and expect them to rebuild their iron stores. Avoid concrete transfusion levels. Just don't tell the nurses if hemoglobin comes back at level X or below, transfuse. You should really transfuse if the patient is symptomatic of it. Don't automatically transfuse 2 units every time. So if the patient needs a unit, give them 1 unit. Don't give them 2. There's no reason to give them 2 straight up. This is a practice that I have done forever and a day, but if you think about it, it's illogical. And I am the worst offender of this. For years, I just said just give them 2 units. Now, I just say just give them 1. And avoid chemical prophylaxis before the initial platelet plug solidifies, i.e. 8 hours to the time of onset, which is typically around 3 to 4 hours. So your time of onset of most of the chemical prophylaxis agents, if you're going to use them, is around 3 to 4, and it solidifies around 8. So, in summary, are drains still needed in the era of tranexamic acid? The answer is probably not, but unfortunately, no one's actually designed the correct study. And if you want this presentation mailed to you or the abstracts listed here, please email me at chrisvertullo@icloud.com. Thank you very much.